All right. All right, I think I'm going to get started now so that we can get this show on the road. We've got a really good group here, and I'll just try to admit people as we get going. But I'll just start. Good morning, everybody, and welcome to this Ask the Doctor Zoom discussion with Dr. Matthew Pianko. For those that don't know me, I'm Michelle or Mickey McWilliams, and I work with Sid Moss, Sid Wave at Cure Multiple Myeloma Corp. Before we begin, I'd like to ask you to keep your devices on mute unless you want to speak. That cuts down on interference noise. Dr. Pianko is Clinical Assistant Professor of Internal Medicine, Division of Hematology Oncology, Rogel Cancer Center, University of Michigan Medical School. His work is focused on care of patients with plasma cell disorders like multiple myeloma, smoldering multiple myeloma, asymptomatic multiple myeloma, MGUS, plasmacytoma, POEMS syndrome, and light chain deposition disease. Dr. Pianko is interested in clinical research and development of clinical trials of novel drugs and novel drug combinations for patients with these disorders. Before we begin our discussion, I'd first like to thank our very important partners, Adaptive Biotechnologies and GSK. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. So thank you. I also want to introduce Sid Moss. Sid, wave if you didn't do that before, founder of Cure Multiple Myeloma Corporation. Sid and his organization are responsible for those great breakfast treats that I hope you all got. So the way this will work is Dr. Pianko will provide us with a little background on himself for those of you that don't know him. Then he'll give us an update on treatments and any other news as it relates to multiple myeloma. Then we'll open up the questions from you. Please use the chat button and type in a question anytime during the discussion. I'll also read questions sent into me beforehand so that so that we please the conversation going. Plus, we'll unmute and take questions from the floor. So if, this is really informal, so please feel free to just unmute and ask questions whenever you want, okay? So that's about it. Thank you, Dr. Pianko, for taking the time to do this, and I'll give the floor to you.
Well, thank you so much, Mickey, for the introduction, and thanks again to Sid, Mickey, and our sponsors for putting this wonderful program together. I'm happy again to participate this year, and thanks also for the tasty breakfast treats that we set up before this program. So, pleasure to meet you all. So I'm as Mickey mentioned. I'm a hematologist at the University of Michigan. My clinical and research practice is focused on multiple myeloma patients. And a host of other things that are in the family of myeloma. I have been at U of M since about 2018. I came from, before that, from New York. I did my clinical training in New York at Columbia and Sloan Kettering, and I've really enjoyed being back in the Midwest. I grew up outside Chicago, and I was an undergraduate at University of Michigan. So it's been nice to be back in familiar territory. And it's even nicer now that the sun is out, and hopefully we'll have less, snowflakes dropping from the sky hopefully soon. Although it's April, so I think nothing, we can't really, have any sure bets until it's, hopefully May. But hopefully, better weather coming in the near future. So, I think that, firstly, I think that it's really, one of the reasons I became interested in myeloma. I connected with a mentor during my training who was a myeloma doctor at Columbia in New York. Suzanne Lynch is her name. And, she got me interested in this. And, I think this, there's so many, interesting facets of the disease. And, there's so much exciting new treatments that have been coming out, even then. And so I think it's something that's continued to take place is that, there's a lot of excitement in new drugs that are coming out for patients that, hopefully will be, good for patients. And I'm pleased to be able to be involved in trying to do clinical trials to bring some of those drugs to patients. So, look, I that's largely my background. I think I look forward to having another hopefully lively discussion today, and happy to take any of your questions really on anything. So I think that maybe we can just start with some of the questions that were provided, unless anyone have any questions that they want to start with.
So I do have some questions that were sent in, and we can start with those.
Okay.
Two of them are about the Evu-Shield shot.
Oh, yeah.
And I think that that's maybe where we'll start, because that seems to be something that people are interested in. One question was, have you seen or are you aware of any unusual side effects from Evu-Shield shots? And the other one was, do you recommend Evu-Shield for myeloma patients? And at what time during what time in a 21-day POM regimen would you recommend that if you do? So can you speak a little bit about that?
Yeah, absolutely. So I think that this is also a really common question we're getting, nearly every day in the clinic. So happy to address this. I think it's an important topic. So Evusheld is a drug that is a monoclonal antibody. Well, there's really two monoclonal antibodies that are given it together as this drug that's named Evusheld. So it is largely aimed at being passive immunity or prevention of COVID disease, and trying to keep COVID mild if someone gets exposed to it. And it in a way is a drug that provides protection without needing to rely upon an antibody response to a vaccine. So as some of COVID vaccinations have been less than ideal for some of our myeloma patients. Myeloma patients on the whole have had better responses, I think, than some with other types of blood cancers like CLL or lymphoma, but still it's not, it hasn't been great. It hasn't been, completely normal. So I think that the role of Evusheld in a way is to provide some additional potential protection in case your antibody response is, not ideal. But I think that's also a controversial topic, because we're, measuring antibody responses and trying to make decisions on antibody responses is also not necessarily standard. So the appropriate use for Evusheld is for patients with myeloma or other patients who have moderate to severe immunocompromise who maybe had a impaired vaccine response. In general, I think the criteria that we're applying and trying to decide when to do this is, interpreting that pretty broadly. I think really for any myeloma patient on treatment, it is something to consider, whether or not that's just, one of the oral drugs like lenalidomide or pomalidomide, or kind of multiple agents. If someone's getting, Darzalex or daratumumab, for example, that I think is more strongly inhibiting of immune responses. So I think that maybe patients on Dara might want to consider Evusheld, more. But I think anyone who's on treatment would technically qualify. Now, I think that initially the issue was that, and this is Mary put a very important question in the chat. Availability has been a problem and has been kind of heterogeneous. I think that initially U of M in like January, early February, we got like 100 doses for the whole institution. And that covers everybody who has like solid organ transplants and myeloma. And so availability was pretty limited. That has improved, at least at U of M. There is a way that we're doing, you're asking your doctor to get put on a list, and then they're scheduling patients to get the shots administered outside. Usually it's outside of the regular infusion hours. They had been doing them on Saturdays, but that's kind of changing. It's variable and varies from place to place. So I think the best practice is probably to ask your doctor about if they think you're appropriate and if they have availability. I think that there was also during the earlier phases of COVID, when the other monoclonal antibodies for the treatment of COVID were more effective and active. And this period of time, there was a website that would allow people to search for access and availability to these COVID antibodies. And I think I have the website here and I can share it. And I actually haven't used this lately. So I will put in the chat if it's useful, great. If it's defunct, my apologies. But this is, I think, the best, the only resource I knew sort of that I think allows people to sort of broadly search nationally where the antibodies might be available, whether it's in, Michigan, or for those of you who are in sunny Florida today. So I think that I put the link in the chat. That might be a place to try to search to see if this might be active and available. So again, my apologies if it's not, if it doesn't work. I'm sorry, but I think the best practice is probably to talk to your doctor to see if they have like what the program is like at the particular institution. So I think other very important points about this. So basically, we're providing passive protection by giving you manufactured antibodies against the COVID virus. That's how it works, and it's a slow release process. So I think it's thought to last about 6 months. What's important to know is that Evusheld can interfere with boosters and with the vaccine schedule. So it is probably important for you to get fully boosted if you can before getting the Evusheld drug, and probably waiting at least 2 weeks after you've completed the booster before you get Evusheld. The reason is that Evusheld, because it's an antibody that sticks to COVID proteins, is if you get Evusheld before you get the booster, then the Evusheld could block and just neutralize that protein before your body's immune system ever sees it. So it kind of is a counterproductive with what the vaccine is trying to do. The vaccine is trying to educate your immune system, giving it a controlled exposure to the COVID protein, the spike protein, and allowing it to develop an immune response. So the timing as it relates to the COVID boosters is important. However, to address the question I asked earlier, timing with relationship to myeloma therapy. From my perspective, the timing of Evusheld with myeloma therapy does not matter at all. You could do it. There's no, scheduling that you need to do around the Evusheld with your treatments, because largely you're just being provided passive protection by the Evusheld, and you don't need to, the treatments that you're on shouldn't interfere with that protection or the ability to get Evusheld. That is a little bit different with the boosters. I think that people have been making some different recommendations with the vaccines and the boosters. Largely, my practice has been to try to hold the steroids, the dexamethasone steroids, at least like a week before, the week of, and the week after. Usually around within like 7 days of the vaccine, I'll tend to have people hold their steroids that day, because there's possibility that the steroids can also be counterproductive to the vaccine responses. So that is, largely I think the important background with Evusheld. So I think if you've gotten your 4 doses of vaccines, then I think getting the booster at least 2 weeks after the last one would be the way to go. And just another question I get frequently that I think just is worth addressing, because the terminology has kind of changed as to what's the vaccine and what's the booster. Largely what's being recommended now, and this changes pretty frequently, is the recommended schedule for vaccination for patients with moderate to severe immunocompromise. Now the primary vaccine series is 3 doses. So the booster is currently the 4th dose. And so the 4th dose, the booster, should be given 3 months after the completion of the 3rd dose. It used to be 5 months, but they've changed it to be 3 months. If you haven't completed the series now, I think it's a good time to do it. I mean, although case counts nationally are low, as we've all experienced, stuff changes in a heartbeat, and I think it's good to get boosted sooner, because the boosters, the vaccines and the boosters take at least 2 weeks to take effect. We think in terms of how long it takes your immune system to respond to the booster. Evusheld should work right away. So, I mean, it should provide you some protection right away. It's administered as injections, intragluteal injections, so buttock injections. And, I think that those, I haven't really, had people have any reactions to this that have gotten this so far. So I think it's been pretty well tolerated. I think so far it seems to, I think be a good idea overall. I think it's unlikely to be harmful, and it's likely, at least at this point, to be helpful. What we can't predict is if if there's a variant that comes around that is mutated in such a way that those antibodies no longer stick to the coronavirus, then the protection won't be active anymore. But I don't think we know of that at this point. So I would suggest to my patients who are on active treatment to consider getting it. So I think that, for those who are not on active treatment or who are, potentially smoldering myeloma patients, largely I think there's some evidence from larger studies of some less than normal, vaccine responses, but people are making antibodies. We've been doing some antibody testing that's available at U of M to either give a positive or negative result. And so I think it's something that I probably would, talk with your doctor about to see if you would, meet criteria for that, and if that might be available. But I'm not regularly recommending that for my smoldering patients, but it's something that I think we would talk about and consider.
So I pulled up the website that you gave us, and it does work. It's not called. They don't have.
They don't have Evusheld on that.
Yeah, they don't have Evusheld on there.
Okay, looks like it must be from the other monoclonal antibodies that were previously given. I'm sorry, I don't know of any resources about trying to identify who has it and kind of where it is, but I would kind of speak with your doctor and if your hematologist or oncologist doesn't know or doesn't have access, you could also ask your primary care doc, trying to see in the network of access, like where you could potentially get it would be that would be what I would do. At least at this point at U of M, I talk to your doctor and we can get you on a list at U of M, and then usually our schedulers, for those of you who get treatment at U of M, schedulers would reach out to you to schedule that infusion at some point.
So it looks like there's a few more questions in the chat. Do you want to, let's see.
Sure. Stephen, I think you had a question about difference between a CT and a PET scan. That's a great question. So happy to address that. So, imaging in multiple myeloma is important. It allows us to try to find bone lesions that are caused by the myeloma. And, for some myeloma patients, there can be soft tissue plasmacytomas or small tumors of plasma cells that can develop outside the bone marrow. And imaging can be helpful for identifying those. So the CT and PET scan. So let me just start with describing a PET CT. So PET stands for positron emission tomography. And oftentimes that is a nuclear medicine test where they use a radio-labeled sugar or glucose as a tracer. And that's a tracer that they'll give to the patient as an injection intravenously right before the scan. And what that does is areas that are using energy will take up more of that tracer and will light up on the scan. And the scan measures the amount of brightness measured by the amount of the radioactive sugar that has been injected in a given area, and will light up, and you can kind of measure what the brightness is and make some and see what's active. Now, normally the heart, the brain, the kidneys light up. the urinary tract, as you urinate out this tracer, that all lights up normally. Areas that are injured, or if you had like a recent infection, that might also light up on a PET scan. It will light up in a probably majority of myeloma patients who have active disease. It will light up, but there is a substantial portion, 10-15% of patients whose myeloma is not identified by a PET scan. So it might be newly diagnosed patients. We know they have active disease. They had a bone marrow biopsy, a lot of plasma cells there, but their PET scan looks normal. This is possible, and I think it is something that we should be aware of. It makes it kind of a test that's not necessarily useful for everybody at every time point. So the important part of the PET scan. So there's really two pieces of it. There's a PET part of it, and then there's a CT part of it. And so what they do is they take these scans together, and then you'll get the brightness information from the PET scan, and then the CT scan will give you the anatomic information, and they'll kind of overlap them, and so that the doctor can kind of see both where the brightness is on the scan and also where it's located in your body. And that's what the PET CT is those images put together. And that helps really localize exactly where the brightness is on the scan to where it is in your body, because the PET part of the scan doesn't necessarily give us the best pictures of the anatomy. And so generally the PET CT sometimes can be referred to as just a PET, but might actually be the combination of a PET and a CT together. That's probably most often how things are done. It's when you get a PET scan, it's actually probably a PET CT as a combined test. A CT provides just the anatomic information. A CT alone provides just the anatomic information, but it does not give us information about brightness or activity. So it really just is like it's not a functional imaging test, where because the PET tells us something about what's growing or using energy or healing, then that means it's functional. So a CT scan, might have use if really, you're less interested in necessarily activity so much as you are the anatomy. For example, if someone suffers a bone problem, a CT scan might be an appropriate test that you could get quickly, that could give you pictures of the bones that might help your treatment team identify ways to try to fix it. So, if you have a bone fracture in your arm, or if one of the spinal vertebra collapsed because the myeloma has made the bones thin, a CT could be useful for the docs in radiology who might do a procedure called a kyphoplasty, where they inject a little cement into a collapsed vertebra. And I think that oftentimes the CT is something we can get quick, generally, easily approved by insurance. You don't have to wait too long to get it. PET scans, generally require prior authorization from insurance. Sometimes that takes a little bit of time to get. Not too long, but those are kind of, I think, the practical differences between a PET CT and just a CT alone. There's also been some efforts to try to develop a CT scans for the whole body as a way of assessing the bone structure in myeloma patients. So one of the things we are very interested in is if there's been any signs of harm from the myeloma causing small holes in the bones or bone damage, and a CT is an effective way of looking at the bones, and probably a more sensitive test than like just plain X-rays. So there have been some efforts to develop these low radiation dose whole body CT scans. And there are some institutions that have been able to put forth these tests and get access to that. We've been trying to get it established at U of M. It's a little bit challenging to get off the ground. Largely, there's a challenge with codes that you need to bill the test to insurance, and there's not a national code for this test yet. So there's a select group of institutions that have figured out a way to get the whole process up and running. It's something I've been interested in doing at U of M, but we haven't gotten yet. That said, I think that a whole body PET CT provides very similar images and is a suitable, appropriate substitute for that. So anyways, I'm getting a little bit off track, but I wanted to provide some, additional info around that question that was a little bit what I thought was pertinent. So just to add one piece to that, the third advanced type of imaging test we have that we use is an MRI. And I think an important question that I've also had is, what's the difference, or why would you do an MRI versus CT or a PET CT? So the value of MRI in myeloma is that it provides better pictures of soft tissue. And so it can give us good information about the bone marrow we can image the bone marrow pretty well with an MRI. And so MRI really gives good detail about fat and nerves and bone. And I think there's additive value in imaging the bone marrow, especially in patients with smoldering myeloma. If you're trying to tell if they have some small lesions in the bone marrow that might suggest they're at high risk of becoming active myeloma, or maybe meet criteria for very early myeloma, that's where we use MRI as an additive test with the ones that I've just discussed. MRIs are also useful if you have any, let's say there's a complaint, an issue, you've got some back pain and there's some possibility of a nerve component, like you've got a sort of sciatica type symptom or numbness and tingling running down your leg or other neurologic symptom. The MRIs are best for use of imaging the nerves and looking at like the spinal cord and the nerves that leave the spinal cord and travel out to the rest of your body. The MRIs will provide better detail about that than a PET CT or a CT scan will. So your doc might choose your imaging based on the problem you have, and I think that these often provide different complementary information.
I just got an email from David. Thanks, David, with a website that lists the locations for the Evershield.
Oh, great! Well, thank you, David. That's helpful.
I'm going to put it right in the chat.
Okay, great.
Find it if I can figure out. Let's see. Yep, right here. No, okay. The other thing is I have a couple of direct messages here and a few more questions that were asked before. This is a direct message from Alan. How much of a concern is UTI to a multiple myeloma patient, assuming a good response to Kipro? Is that right? Does this type of infection cause any future issues?
Good question. Generally, I think that myeloma patients are at more risk of infections generally. Upper respiratory infections quite commonly because of the effects on our antibodies from myeloma, suppressing our antibody responses. UTIs certainly do affect myeloma patients. I don't know that they represent like a necessarily specific problem, but I think if they generally respond well to Cipro and get cleared, hopefully that won't present an ongoing issue. I have had patients who've had recurrent urinary tract infections, and this isn't necessarily something that's specific to myeloma, but sometimes with repeated antibiotic use, sometimes they can become resistant to antibiotics, and sometimes people might even have like a bacteria that's just colonizing but not causing infection in their urinary tract that people can get repeated cultures with and can still find. So I guess I would probably work if you have, hopefully that issue, goes away and, with the Cipro, but if it doesn't, it comes back, I'd probably just work with your doctors to make sure you're getting urine testing and urine cultures so that they can, pick the right antibiotics in case it's not going away. And, if it still isn't going away with multiple antibiotics, sometimes I've had my patients see a urologist and, sometimes the urologist can, sometimes someone will have like a bladder stone, and sometimes the bladder stone might have a little bacteria in it that is not the reason why it's not clearing. The antibiotic can't get like into the stone. Anyway, I hope that issue goes away. It doesn't necessarily represent like a I think, a specific problem that's more of an issue in myeloma patients compared with others. But certainly in general, infections affect myeloma patients as a common issue.
Thanks, Dr. Pianko. I
Yeah,
appreciate it.
yeah, no problem. Hope it goes away quick. So I think there were some other, Mickey, unless you wanted to, if you have some other direct questions, I could probably just move on and with some of the in the chat. Is that okay?
And the chat's great. And then I'll throw in a few other questions if they don't come up in the chat too.
Okay, great. So Mary asked, what is the difference between the drugs that block bone degradation and those that build bone? Why are the bone builders not administered often, but the bone degrading blockers are? It's a good question. So I think, and let me just try to interpret that and see if I'm understanding the question right. So in general, in multiple myeloma, we use a couple different types of bone strengthening agents, and those are, the most common one we use is called Zometa or zoledronic acid. It's an intravenous treatment that can be given either monthly or even up to quarterly. And the role of that is that it's been shown in myeloma patients as well as other patients with cancers that can affect the bones to be effective in reducing the risk of having a bone problem, such as a bone fracture or a need for surgery to fix a broken bone or radiation to a bone. So in general, we have used these for quite a long time to help reduce the burden of bone disease in myeloma patients. So it can help with reducing the risk of fractures. For those who do have some bone pains, I have had many patients tell me after they've started some of these Zometa treatments that their pains can get better. And what it is it's the name of the drug is it's bisphosphonate. And the way I like to think about these is that they are a type of drug that, if you think about the bone structure-wise, it's like a big scaffold, and it's like a big network of scaffolding. And what you're trying to do is strengthen the scaffold. And what myeloma has done is it's taken pieces of that scaffold away and has removed, layers of the scaffold. And what we're trying to do is to, first stop the myeloma from breaking down the scaffold by using myeloma drugs to make the myeloma inactive. And by providing myeloma shifts the whole bone turnover process towards breaking down bone. There's normally a balance between cells that build bone, called osteoblasts, and cells that break down bone, called osteoclasts. They usually work at about the same rate in people. Myeloma cells cause that whole process to be shifted towards breaking down bone. They inhibit the cells that build bone, and they drive more of the cells in the bone at the bone turnover sites to be bone breakdown type cells. And so the Zometa drugs, what they do is they kill the cells that break down the bone, and they also serve as pieces of scaffolding that can be built into the scaffold as the body shifts back towards building bone back up. Zometa can stay in the bone structure for quite a long time. So generally the recommendations for newly diagnosed patients is that people get about 2 years of Zometa and then stop, and then consider starting it at the time their myeloma relapses or becomes active again. Oftentimes treatments it's quite individualized with this, because people go through different, they have a different degree of bone problems, and there's a different the use of this is varies, I think, pretty widely, but generally I think it's recommended at some point in time for all myeloma patients. So I think that drug, technically I think helps build bone, but also referencing Mary's question, it blocks the degradation of bone by killing the cells that are doing the bone breakdown. And I think it has long-lasting effects. There is another drug that has come out which is an antibody type drug that's called Xgeva. I don't know if any of you are familiar with that drug as well. So it's also called denosumab. Now, this is a drug that's administered generally monthly. It's an under the skin subcutaneous injection, in contrast to Zometa, which is IV. It's been a recent addition to our toolbox for helping address bone disease in myeloma patients. The reason, the place where we consider Xgeva or denosumab is for patients who have severe kidney problems. If the kidney dysfunction is severe enough, the Zometa we can't use because it might pose a problem to the kidneys for people who have the creatinine clearance level is like 30. So if your GFR, your creatinine clearance is below 30, we generally won't use Zometa. If you have mild to moderate kidney dysfunction, we can give smaller doses of Zometa and it's still safe. But if the kidneys are hurting too much, then generally denosumab is what we'll use. Now that blocks, instead of killing the cells that break down bone, it prevents them from maturing and it blocks them from becoming active, but it doesn't necessarily kill them. So, and it doesn't also build into the bone structure. So it doesn't necessarily build bone, but it does block bone breakdown. And generally, I think its use is a little bit more limited because I think the effects of it are not long lasting like Zometa. So I prefer to use Zometa because the effects are long lasting. If I have a choice, the effects are long lasting. It's cheaper, and also I think that the relative benefit of Xgeva over Zometa is I think not necessarily proven. I think it's another choice. It's another option that's out there. It's faster to give. It's easier to give. The downsides with Xgeva that people can sometimes have low calcium levels after getting it. So I think that another piece of this is that generally I recommend that my patients take a calcium and vitamin D supplement that helps give your bones the raw materials for building new bone, and I think is a good idea. But I'd talk with your doctor about it to see if it's appropriate for you. So again, sorry, probably more information that was in the question, but I wanted to provide, I think, relevant, background around that question.
Do you want to just keep going down the chat?
Sure. Yeah, that works. So question from Judy. My husband has both myeloma and AL amyloidosis. He had the 2 vaccines and then the booster was in November. He was given Evusheld in February. Should he get another booster now? So this is a good question. I think I would definitely review the schedule with your doctor. Generally, I think that 2 months after Evusheld would probably be in the period of time where it would be too soon to get a booster because the Evusheld would probably interfere with it. What I would do is communicate with your doctor and find the most up-to-date information about exactly when would be appropriate. I think probably my gut feeling would be around 4 to 6 months after the Evusheld would be a time that you could consider getting the booster. And I think this is new territory. I haven't had any patients that have needed dosing of Evusheld yet, so that might be something that might become pertinent, later in the summer or early fall as we get 6 months out from the last Evusheld dose that has been given. So. Relevant to that specific question, if they had gotten 2 vaccines and then the third dose was when they were calling the third dose the booster in November, I do think that getting the 4th dose of the vaccine would be recommended when they are able to do that. And I think the general ballpark time for that would be around 4 to 6 months after the Evusheld. But I would work with your doctor to check the up-to-date recommendations for this because those recommendations have been changing so often that I'm frequently finding myself navigating to the CDC website just to ensure my recommendations are up to date. Great. So, and then there's the link from Mickey in the chat for finding the Evusheld. Question from Mr. Ralph. What do you recommend in taking a cyclovir post autologous stem cell transplant or ASCT? Specifically, I'm on maintenance, have had Shingrix, and had shingles after getting the Shingrix vaccine? That's a great question. So I think the Shingrix vaccine is something that is relatively new. I do think it's safe for immune compromised patients. So I think that it's something to consider to talk with your doctors about potentially getting. But the problem is like other vaccines, myeloma patients, because myeloma is a tumor of the plasma cells, and plasma cells are generally what make our antibodies. Antibody responses to vaccines are not the best. So it's possible that people can get shingles after having had the shingles vaccine. So I think that probably, in general, my recommendations are to consider continuing the acyclovir for about a year after the auto transplant at least. Then what to do? I generally try to suggest people continue if they're not on a drug that's a proteasome inhibitor, which is Velcade, carfilzomib, or ixazomib or Ninlaro. Those drugs we think specifically heighten the risk of shingles. Daratumumab as well. I generally have pretty liberal about continuing acyclovir in patients as prevention. If someone's just on maintenance with Revlimid and it's been a year since your transplant, I think you could consider doing acyclovir. If you've had prior shingles, I would probably just continue acyclovir. I think it's a relatively harmless prevention. I know it's a nuisance and they're kind of big, they're big pills and it's annoying to take them, but I generally think it's probably worth the protection because acyclovir and the shingles and the nerve pain from shingles is like such a bother that I feel like it's worth the trade-off, even if it's a daily thing. So I'm sorry that you went through that, and I think probably continuing if you've had a breakthrough case of shingles, I think probably erring on continuing it would be reasonable. But generally, my practice, to go back to your question, let's say we take the if you had shingles out of that question, I usually do it up to a year after transplant, and then talk with my patients to see if they might want to discontinue it after a year if they're just on Revlimid. Okay. If they're on ixazomib or they're getting Dara or one of the other myeloma, I usually just continue it because I feel like it's just the risk benefit, the balance of it being worth it, I think just makes it worthwhile to consider doing it. Yeah, thank you for the question. I think that I get the question about Shingrix. They're like, well, doc, I had the shingles vaccine. Like, do I still need acyclovir? Should I do it anyway? I generally suggest that people still do it at this point because I don't know that I can fully kind of trust the Shingrix vaccine enough to say that people don't need acyclovir at this point. Another option that I've talked about with some of my patients in general is valacyclovir. Valtrex is another formulation of this of acyclovir that is potentially an option. I generally do acyclovir more often, but Valtrex is something that's like a once a day tablet that could be considered. But out of practice and training and I've just, and most of the time I think people are using acyclovir still at this point.
I do have some more questions that came in earlier, and I'll probably mess these up because I'm not very good at some of these drug names. But this one came from Stephen Hall. Possibly for successful ASCT for older patients, I am 73 in fairly good health with M-spike 0.3, but IgG, I think that, or LGG and serum kappa have begun to increase. So,
okay. I think that just to try to rephrase the question. So I think the first question is to rephrase is the question, should I go through an auto transplant or should I do an autologous stem cell transplant at this point? Being an older adult and with numbers starting to climb up a little bit. Is that the right question? Is that the question? Okay. Yeah. I think it's a good question. Generally, autologous stem cell transplant we think is a safe procedure. Even for older adults. we have transplanted patients in their mid 70s, mid to late 70s. It's probably more about your biological age and the other medical issues that you have that will help clarify if you're a candidate for stem cell transplant or not. In general, we oftentimes like to have patients go to transplant with the numbers low or stable. It's possible that in talking with your doctors that if their plan is they can get you to transplant soon and they want to move ahead with that, it's reasonable to consider doing the transplant. But one of the questions might be is, heading into the transplant, we kind of like to have some disease control, because we think that if you do the transplant, you'll then likely need to be off all treatments for at least 2 to 3 months after the transplant, and it sometimes we like to have things looking good going into the transplant, so that we don't have guarantees that transplants always work 100% of the time. So I think what it is helpful, I think, to have the numbers be stable going in, but likely the response to your question, not having access to kind of all the background, I think I don't know that I can fully confidently answer your question, but I think that it be something I would talk with your doctors about. The pace of increase of the light chains or the M protein is also an important feature. If there's a very minor increase, that might not be significant, and that could be a reason to just go ahead and do the transplant. We've largely seen that transplants are effective treatments for myeloma. The people in general who do transplants have longer periods of remission than those who don't. There have been a lot of data trying to explore, well, do we need to do transplant first as part of the initial set of treatments, or could we do it later? There was a large trial that was carried out both in France and the United States, looking at the most common standard type of treatment we use for myeloma with Revlimid, Velcade, Dex, or RVD treatments, followed by, they did a study looking at whether or not patients got a transplant up front or potentially delayed it to later. And patients who went through that, they got RVD, the first arm got RVD, transplant, a little bit more RVD, and then maintenance. Group that would be, let's say, just group 1. The average amount of time for the myeloma came back and needed different treatment was about 50 months in that group, over about 700 patients total. The other group who saved their stem cell, they did RVD, they saved their stem cells but delayed the transplant, had about 36 months before the myeloma came back and needed different treatment on average. That's an old study now. They presented follow-up data from that trial at the American Society of Hematology conference, I think a couple of years ago. It's about 8 years of follow-up. And at 8 years, the intent for that trial is for the people who didn't get the transplant up front, that they would do it then later when their myeloma relapsed. And the summary from that was that basically the same amount there was no overall survival difference in that between comparing those two groups of patients. So patients who got transplant up front lived about the same amount of time as patients who did transplant later. The question relevant to your case is that, well, you're 73 and you've got a window potentially to do transplant. It could be that you'd be eligible for transplant now, but we don't know what the future holds. And let's say some unanticipated thing comes up, and let's say you were to have your myeloma come back and you'd be 76 or 77. Maybe be more reluctant about doing a transplant at that time, and that would mean that we might leave that treatment out, like, off the table for you, or you might defer it now and then not be able to do it later. There's a lot of tools in the toolbox for myeloma. I think in general, transplants are something that should be considered, but they're not for everybody. It's an individualized choice. I think you've got to go through the pros and cons and know, talk with your doctors about what the rationale is for doing it. I think that the rationale for doing it is it seems to prolong the amount of time before the myeloma comes back. On average, that seems to be about 14 months longer in those patients who do the transplants. I have had patients who did transplants in the early 2000s, and myeloma has been in remission for a super long time, and they've done great. I have other patients who've had their transplants, and unfortunately their myeloma started relapsing within 6 months of their transplant. And that, that's heartbreaking to go through, like, being admitted to the hospital, going through all this stuff, have your myeloma come back. Unfortunately, I wish we had the tools to say up front, like who's going to benefit and who's not going to benefit. So there's no guarantees, unfortunately, but we are still recommending transplant in general for those people who are eligible for it. I think it is a useful tool. It's something I think I generally recommend, but I think that there's a lot of gray in that for someone in your situation that is likely going to be based on your individual case. So no, we can't just blanket make recommendations for everybody. It's all myeloma care has got to be individualized, and so this is a very common question I get, and I think it's one that it's got to be tailored to you, and we've got to talk about being an informed consumer of what you're getting and what the data shows about transplant, and is that worth it to you. So I think that most of the time I get that question, the numbers aren't really rising. So I think that is a variation on in your specific case that needs to be taken into account when making this decision. That's different probably for most of the time. Most of the time when I'm entertaining these questions, people numbers are improving and have already gotten a lot better and are stable, and we're kind of debating, okay, so I'm better now, like should I do this transplant or not, is most of the time I get that question. The variation in your case is that the numbers if those are slightly going up, I think we need to be an important conversation to figure out if those are rising in a clinically significant fashion, or is it just like a small little blip? And that's probably going to be an important conversation you need to have with your doc.
I have
the question.
I have a couple questions that came in earlier that I'll just interject right now to make sure we get to them all. This one's from Angel. It's, if my ANC is only 1.1, is it dangerous to get a fourth COVID shot?
Good question. I do not think that there's any risk of getting COVID shots with a low neutrophil count. I think that it would be my recommendation I would go ahead and get the booster. I don't think that that's likely to result in increased side effects from the vaccine or any risk to you. Largely my concern is just, not having guarantees about how well the vaccine is going to work and provide you protection, I think is a general question with you and with any, myeloma patients. But I think that largely we're seeing most patients make antibodies to the vaccine. So I think it's worthwhile to go ahead and get it.
Okay. And there's a couple more in the chat. There's one that I can see and one that everyone can see. So
okay, I can address the one from Cynthia. So being on Velcade, does acyclovir interfere with its use? It does not interfere with its use, but in fact, I think the reason that you're on Velcade would make it very important to be on acyclovir, because Velcade substantially increases the risk of shingles, and the acyclovir is needed to prevent the shingles. So I definitely would be on it if you're on Velcade. And even up to a year after stopping Velcade, I think I would continue acyclovir.
Here's another one that I got in advance from Laura Bates. I had a CAR T cell transplant in a clinical trial a year ago today. Last month was the first time that all my blood work was perfect. In fact, my immunofixation said no monoclonal proteins detected. This month it says a poorly defined area of restricted protein mobility is detected, and it is reactive with IgG and lambda and antisera. I have not heard that terminology before, but my biggest question is, can proteins wax and wane with CAR T cell transplants like they can with a cell transplant?
Great question. Well, Laura, you find yourself in a minority of patients who've been able to get access to CAR T cells. So wonderful for you for going through all that. And I hope it's been a good experience, overall for you. In general, like with any myeloma treatment, I think it's possible that the lab results could wax and wane. I think that persistent changes in the serum protein electrophoresis or immunofixation would be important to follow. So I think that getting a follow-up test when you're next due, would be important to follow up on that result. It's possible you could have waxing and waning findings after CAR T cells. It may or may not be significant. And, it's hard for me. I think I would probably say if I were the doc treating you and I were, seeing this result and we were talking about it in clinic, I'd say, well, I wouldn't be too worried about this, but I'd say, let's just check another set of labs in the next month because, I've had patients get sick or colds and then they get their protein electrophoresis and the antibody that was made to respond to whatever sickness or infection they had shows up in their immunofixation and there's a transient blip and then it goes away. So I don't think it's necessarily a reason to be worried, but I would pay attention to it and probably get it repeated. It sounds like a non-specific finding from the immunofixation. If that description is something that's written by a pathologist looking at the blots in the lab and then typing out a description. So I think they're just describing what they see, and I think that the way that they wrote that report as it was discussed in the question, it sounds kind of non-specific. So and I think was your myeloma previously, did it make an IgG lambda M protein?
Laura.
Yes, it did. And I had a stem cell transplant and was in remission for 9.5 years. And then I had the CAR T.
Oh, okay. Well, I think that it's certainly something to pay attention to. There are, I have patients who've had stem cell transplants, like you, very long time ago, and they've always had, they've had either a trace positive M protein or an immunofixation that sometimes is negative and sometimes positive. So I don't know what necessarily to tell you about, kind of what to expect, but I would say that I wouldn't necessarily be alarmed at this point, but I think you would just want to pay attention to that and, keep an eye on it just to make sure that, if there's any activity that your doc knows about and you guys are watching.
Yeah. Okay.
I'm sure you are.
Yeah, I know, like there's some treatments like Dara where you can get a protein spike that's from the treatment, not from the myeloma. And I didn't know if that was true with CAR T treatment.
So probably not the case with CAR T treatment. Dara and other monoclonal antibodies such as elotuzumab, even potentially Evusheld, just to go back to that earlier comment, is also
okay. Well, I did
antibody.
have the Evusheld vaccine in January.
Okay. Evusheld, most of these monoclonal antibody drugs are generally IgG kappas, most of them. I actually have to look to see if what type Evusheld is, but maybe while we're talking, I can look into that. But that could be another explanation for it. But we shouldn't see that from the CAR T itself.
Okay, thank you.
Yeah.
I have one more question in the chat that I can see. This is from Alan. In your experience, does CAR T work better than a repeat autologous stem cell transplant if you relapse and need additional treatment for MM?
So just to rephrase the question, the comparison between repeat autologous stem cell transplant versus a CAR T at time of relapse for myeloma. Fabulous question. Great question. I don't think we know. I think that in general, we are doing second transplants less often these days than in the past. Generally, we still collect cells for all of our patients to be able to do 2 transplants. There's probably a minority of patients that are actually going forward and getting the second transplant, largely because there's a lot of other options that are available. We tend to think and try to estimate, okay, is the question, should we do a second transplant? The way we think about that is to say, what was the duration of time that someone was in remission after their first transplant? And then we think about, on average, generally it's probably half the time, or we're not going to expect the same length of response out of a second transplant than we would expect out of the first time. So generally, if the response with maintenance was less than 3 years, we wouldn't consider doing a second transplant. I probably would then just go forward and do a CAR T rather than doing a second transplant if the response to the first transplant was short. If I don't think we have comparison data comparing a second transplant versus a CAR T. At this point, my thought would be, I think that if I had a patient that had access to both, I would probably lean towards them considering CAR T at this point in time instead of doing a second transplant. But I think that would probably depend on the situation. If like Laura, they had a transplant 9 years ago and they came back to me this question, I'd say, well, 9 years, pretty great. Second transplant, if we think that's half the time, another 4 or 5 years from second transplant, that sounds kind of appealing. But look, we're in this era now where CAR T cells are becoming available. I think that's another controversial topic, which we can talk about. But it's a tough decision. I don't think we have data comparing a second transplant versus CAR T, although it's a highly clinically relevant, I think, question that hopefully someone can do that study. But it's also probably will be a hard study to do. So we're in the infancy of CAR T cells at this point, and hopefully we could answer that question at some point in the future. But I think it's a really good question.
Thanks for the answer too. I appreciate it.
Yeah, of course.
So
Of course.
we're at the end of the hour, but I wanted to just ask anybody, if you have another question, just unmute and ask right now before we end this discussion. And so if you have anything else, just blurt it out, because we only, I don't want to take up too much more of Dr. Pianko's time. We appreciate this whole hour. So go ahead.
Michelle, are you going to introduce Molly?
No.
No?
No, not until next week, next time.
Oh, okay. The only other thing is we are planning a wine and dine this year. We're back to the old wine and dine, and it will take place, I think, the last Thursday in September. So I think the 28th or 29th. 29th. So I want to let people know about it.
Well,
Okay,
wonderful.
thank you.
That's exciting. Thank you, Sid. And thank you again for running this wonderful series and for running the wine and dine. I hope I can attend this year. Hopefully won't have any childbirth issues or like I had like an upper respiratory illness that happened, that was very ill-timed this last year. So I'm sorry I've been inconsistent, but I can say that it's been out of my control.
Right. Well, we certainly appreciate it. Thank you.
Well, thank you all for for spending time with me this morning. It's really been a pleasure. I'm more than happy to answer any follow-up questions that come up. You could maybe just send them to Mickey and I can try to respond to them separately. Happy to help at any time, I think I'm grateful for the questions and, wish you all the best and hope you guys can enjoy a happy and healthy spring. And, let me know if there's anything I can do to help any of you.
Thank you.
Dr. Pianko.
Thank you so much. And thanks everybody for attending today. This is, it's always very interesting. So take care, everyone. We're going to end now unless anybody needs to blurt out anything. Okay, take care. Thank you, Matt.
Great. Thank you. Thank you, everybody. And thanks again, Sid and Mickey. This was very nice. And thanks again for the breakfast treat. Yeah.
Thank you.
All right.
Thank you.
Bye-bye.